Thanks for taking the time. Now that it's a few minutes after, I think we can get started. We're really excited to have you all here to talk about one of the hottest topics of the day, GLP-1s. We think it's a really exciting time, but also a very challenging time in weight management. As you all know, there's incredible disease burden and quality of life issues and costs associated with the comorbidities that are and risks that go along with weight management issues. So it's a really exciting time because we've got all these really effective tools to tackle the problem, but obviously it's creating a lot of pressure on you all. So I keep saying to our team that this is certainly not the first time we've seen an example of a blockbuster drug or a really effective, successful therapy that just has a really high price tag. I know you all have lived through this with other therapies that come out, but given the numbers of people who are interested in these therapies, and really given the crazy influence of social media, it's no longer just a pharma marketing thing anymore. This is really creating a ton of pressure on payers and providers. And when I talk to providers, it's providers you wouldn't even expect who are getting asked about these therapies. So there's clearly pressure on folks to have an answer, and payers are in a really difficult spot trying to determine who should be on these therapies and who should not be on these therapies, and really trying to balance the costs with the demand from individuals, but also the fact that you may have a bunch of employers. We're hearing from a lot of you that people want the program for their particular employee population to maybe look very differently from one of your other employer customers. And that may look very different for you from how you want to treat your fully insured books of business. So it's creating configurability challenges for you and putting you in a little bit of a tricky spot. Really good news is there's lots of effective tools in the toolbox. The challenging news historically, and I think this is really changing and what we're so excited about, is that there's been a lack of awareness of some of the alternative effective therapies out there, and the pros and cons to those options, a lack of education around those. And really to date, there has not been connective tissue between these tools. So your lifestyle solutions have never really been connected to your pharmaceutical or clinical therapies that are coming out. So as is always the case with what we do, we think it's really important to get the right person to their right option so that they can be as successful as possible. Preferably, that's the lowest cost option that works for someone, and do it in a really efficient manner, whether that's a GLP-1, whether that's a lifestyle change program, whether it's both, or whether it's neither. So that's the kind of stuff we're going to cover with you today. We're going to talk about many of the challenges posed by these therapies. We're going to talk about some of these solutions, including different strategies that payers can utilize to manage costs and demand. A little plug about what we're doing. We've had a lot of conversations with a lot of you on this call and gotten your feedback to refine our offering. And so we're very excited about our ability at Solera to combine lifestyle programs and these clinical solutions in a way that meets the needs of all of your stakeholders. And we can do that in a configurable way so that you can have different approaches depending on book of business or depending on ASO preference. And again, we worked with you all to refine the strategy and our solution around that, to really try to get it right. So you'll hear more about that in the coming days and during this webinar. Before I pass it off to Dr. Crow, I do want to introduce who's on the call with me, and I'm Mary Langowski, the CEO of Solera. Ed Leibowitz is also on, and Dr. Byron Crow. Wave at everybody, guys. They're going to be talking you through the rest of the webinar, and they'll talk you through some of the market trends we're seeing. But I want to emphasize, don't just let us talk at you. Please participate. If you've got questions, don't hesitate to interject, raise your hand, interrupt us. The more of a discussion we can have, the better I think that this will be, and it'll be more helpful for everyone. And if you want to share insights on what you all are thinking about doing inside your respective plans, I think that would make it a really fruitful discussion. So with that, I'll pass it to Ed and Dr. Crow, and we'll get started on giving you some overview of what we're hearing in the market, and feel free to participate in the discussion. Thanks, everybody.
Well, thanks, Mary. As Mary laid out, it's an incredibly interesting time in this space with a really powerful medicine that has been priced in a way that creates serious sustainability challenges if it's deployed at scale. That's no surprise to folks on this call. What we wanted to talk about today, in addition to the economic implications, are options for plans and employers around how to deploy these solutions in a way that balances multiple competing concerns, improves configurability options, and improves operational excellence within the plan. You know, it's an important thing to think about that we've had medicines to manage obesity in the past, and we're seeing new trends in those medications. And, you know, in this whole conversation, we've heard a lot about, in a way, blaming patients and being surprised that people are seeking these medicines out. And recent survey data shows that that's not the whole story. Actually, people are pretty thoughtful about these medicines. And when you really talk to them, sit down and talk to them, not just write a prescription, but help people understand the implications, people's attitudes are different than we might expect. And there's a lot of gray in between the black and white messaging that you might have seen in the media. So with that, we can dive into the presentation, and I'm really looking forward to the conversation. So we have 5 objectives today. The first, talk about major trends in GLP-1 uptake and cost impact. This won't be a surprise, like I said, but we'll just put some numbers around it and help highlight the broader societal implications of the cost of these medicines. Provide an organizing framework, thinking about the many tensions I'm sure you all are feeling around prescribing in this area, whether from individuals, employers, et cetera. Then go deeper into those patient attitudes towards the drug and talk about emerging trends in step therapy before I'll turn it over to Ed to highlight some of the operational complexity of GLP-1 step therapy and how technology solutions can support better operations for plans and ease the burden of prior auth and step therapy as an operational challenge. So these stats aren't surprising, right? This is a major advance in obesity medicine. Demand is increasing in a dramatic way, in no small part because I have to say, in healthcare, you know, we get served ads all the time for medicines, and, you know, ask your doctor to prescribe you whatever. But there's certainly a cultural element to this that has been exceedingly powerful, right? We have TikTok influencers and others. Elon Musk is out on the street talking about how he's on these medicines, and that's increased visibility quite a bit. And so we're seeing that in the rise of prescribing for this. So 6.5% compounded annual growth rate in prescriptions. We had a plan say that they were seeing $1 million a week in potential pharmacy costs from new prescriptions for GLP-1s. And then at scale, this leads to over $1 trillion in added costs to the healthcare system. It's really striking to think about that in terms of just total spending and the potential increase. I mean, that's you know, significant impact to the GDP. We won't go deep into this slide, but I just want to put some numbers around it in terms of premium prices. So if you think about if we ballpark the average per member per year premium at about $7,900. If everyone with obesity in the United States who was eligible for this medicine starts taking it, those premiums rise by 64% and push up over $12,000. So you can see the incredible impact that these medicines have on cost, and the real need to manage that cost in a sustainable way. But there are, of course, competing tensions and competing priorities, which is, we'll flip to the next slide here. So right now, most insurers are not covering these, only about 30% of plans as of June of this year. And only about 12% of the population is covered by these medicines in a real world study. But about 1 in 5 employers are still, as of this time, planning to cover these medicines. So it creates an interesting dynamic where there's a small but important minority who does want to see these medicines covered, and creates a new challenge to say, hey, how do we address all parties? How do we make something that works for those who want other options, aren't ready to commit financially to these medicines, and also work for those who do want to are willing to take on the cost of the medication. Now, if you actually ask individuals, though, 80% of adults believe these medicines should be covered by insurers. That number declines a little bit when you let them know, hey, that's great, but your premiums are going to go up. That number drops down to about 50%. The point being that public sentiment is largely, at least in broad strokes, in favor of these medicines, and they're concerned that they wouldn't be covered. And then this is just, an easy Google search shows you how much marketing is going on out there, right? The first 5 sponsored links on Google when you type in GLP-1 are to, go get your prescription, we'll get you on a GLP-1. All you have to do is click this button. So there's consumer sentiment that, yeah, we should be doing this. And there's plenty of folks out there who are willing to take people up on that and say, great, let's get you started. Whether or not we're actually doing really good counseling around that is, that's another story. And then payers are caught in the middle. There's the obvious demand for this, and when we say no, it creates a lot of friction and abrasion. There's a regulatory component of this around medical necessity. Hey, these are objectively good drugs. They're included in current guidelines, but they come at a huge cost. So payers are trying to balance abrasion, financial stewardship, with medical necessity concerns, and trying to figure out what comes next. And we're hearing that from a majority of our partners, that these are all the major concerns, and coming up with a solution that solves for all of them and balances these tensions is what we've set out to do with the way we're approaching this landscape, and the way step therapy can play a role in mitigating these different competing priorities. But what do patients actually think? If you actually sit down with individuals, how are they viewing these medicines? And a recent Kaiser Family Foundation study gave us some really great insight into this. I was really glad that they did this study. So in July, the KFF, they did a national survey, looked at over 1,000 US adults and asked them about their attitudes towards new GLP-1s. The 2 key findings from that survey, the first is that, as you can imagine, most people had heard about this. So 70% of adults have heard about these new drugs, just a testament to the incredible marketing that's been going on. And then if you actually look at people who are trying to lose weight, and ask them, hey, are you interested in a medicine like this? For those who want to lose 20 pounds, 68% were interested in these drugs. Yeah, I would, think about this. I'm considering it. But the key thing to note is that the interest is not as fixed as you might think. So I think there, just from my own perspective, there have been a lot of reports in the media portraying this as almost a gold rush for these medicines. Everyone wants to take them who's eligible, and you can't tell them otherwise. But the Kaiser study actually suggests that that's not exactly the case. What we do see when we look at the clinical literature is that when individuals stop taking these medicines, they regain most, if not all, of the weight, which is suggesting to a lot of us. And I've, just had a great conversation with a past president of the American College of Lifestyle Medicine on this. And we agree that we think these medicines are probably medicines that people will have to take for the rest of their life, in order to keep the weight off. When you actually inform individuals that, hey, you're signing up for a long-term commitment, interest declines by 70%. When I see patients who've had a heart attack, I have enough trouble convincing them to take a statin, which is a pretty benign medicine that's life-saving for people who have had a heart attack. substantially decreases their cardiovascular disease risk. And yet people still don't want to take them because they just don't want to take a medicine. So when you actually help people understand that long-term implications of these medicines, this isn't a short-term thing, this is something you're going to have to do for a long time, people want a different option. And that's coming from them, not coming from an alternative source. But that level of education and awareness building is not always present in the way that these drugs are currently being marketed to patients and consumers. So step therapy is emerging as a really coordinated and elegant approach to managing GLP-1 demand in the growing market and balancing these competing concerns, while also helping individuals make choices that still work and are going to get them to a better place in terms of their health without having to sign up for a lifelong medicine. We'll talk about a few of those trends that we're seeing in terms of how step therapy is being configured in the market and how we're thinking about it. So in terms of the three biggest trends in the step therapy landscape, the first is the trial of lifestyle change. So if you think about the world of cardiometabolic health, lifestyle change remains the foundation of lifestyle medicine and of addressing obesity and cardiometabolic disease. We all know that we should make changes like getting more physical activity, eating better. These are things that we're taught for a long time, and people know they should be doing, and truthfully, they want to do. Most people want to be healthier in this regard. And many people succeed when they do actually engage in lifestyle change. They lose weight, they feel better, and many of the concerns around weight, health status tend to subside. Not all of the time, but in an important part of the population. And so that trial of lifestyle change up front is proving to be an appealing part of the step therapy path that gets that foundation right that you can then build upon with subsequent therapies, right? If someone's lost 10% of their body weight when they've done a lifestyle change program, they're feeling good. Now they're much less likely to say, you know what, I did all this and I still need a medicine. Instead, hey, actually, I feel pretty good. I want to stay where I'm at for a while and see if I can manage this on my own. For those who are interested in a medication, we're starting to also see a reemergence of what we call the Gen 1 anti-obesity medicines. These are older medicines that have been around for a while. Some are FDA approved, some are used off-label for weight loss, but these are things like metformin, bupropion, naltrexone, phentermine, orlistat, all of which come at a lower price point and can still achieve a meaningful amount of weight loss. And then finally, and this ties back to the other slide, when you actually educate members on what's going on and connect them with high-value providers who aren't just incentivized to write a quick prescription, but are incentivized to sit down and talk with someone and really dig into their motivations and attitudes, you can get a lot of people to take a different path. So when you combine these three things together, you have a very nice way of progressing someone through all the things that they need to do to manage their weight, which is a long-term commitment for individuals with overweight and obesity. With that, I'll hand it over to Ed to talk more about the operational challenges associated with GLP-1s and how technology plays a role in what we can do differently in this space.
Thanks, Byron. And Taylor, if you could go to the next slide, we'll start on. So as Byron was saying, if step therapy is really the answer to the challenges associated with cost and outcomes with GLP-1s, there's a lot of challenges that you all would face at your health plan to actually implementing it. The first being, as you think about GLP-1s, the data needed to institute step therapy, or even at its lowest level, prior authorization, requires transforming lifestyle variables into clinical events, right? And that is something that's not traditionally been done. If you think about your usual prior auth workflows, and something like somebody gets an X-ray and then making it an MRI, and that's what's required to have it paid for. But with the GLP-1, it may be somebody should be in a lifestyle management program for 3 months. They should lose X% of their starting weight. They should read an article on healthy eating, and they should watch a video on, better exercise, right? You can figure out what the variables and activities would be. So in implementing these prior auth workflows and the data that unlocks the gates to the next step of step therapy, really have to identify systems and solutions that can bring in that non-traditional data set, right? The engagement with something like a Weight Watchers, the engagement with something like even an exercise gym, and transform that into a clinical event code so it can plug into your prior auth workflows. And that's different than some of the things that you're seeing in the marketplace today. If you go to the next slide, Taylor, where there's a lot of great solutions out there, right? Lots of folks have been doing diabetes management and lifestyle coaching for many, many years and having success with it. But you've seen an explosion of kind of the Me Too movement for GLP-1s, where all of these point solutions are saying, oh, but wait, what we've been doing can now work for GLP-1s. You may see a health coaching platform that says, oh, if that member is on a GLP-1, well, we can work alongside them to coach them on that better. Or you may see content providers that say, oh yeah, we're gonna, prioritize the content that somebody on a GLP-1 sees around protein or strength training to avoid some of the repercussions of losing weight really quickly. Or other partners may be saying, we've been doing deprescribing for years for things like metformin and other type 2 medications. We can do that for a GLP-1 as well, right? Now, in and of themselves, there's nothing that's terrible that these guys are doing. But what the challenge is they're taking their old model, applying it to a new therapy, and not thinking about the comprehensive needs of that individual. And more importantly, not figuring out how to transform those data variables to get them back into your systems to enable clinical workflows, right? So there's lots of challenges with retrofitting those solutions. And then lastly, as you think about what the consumer wants and how you enable that step therapy program, there's a few things that you need to do to make sure that member abrasion and member friction isn't created. So as Byron mentioned about the KFF study that was done, for folks that are looking to lose weight, 60 to 70% of them are like, yeah, you know what? A GLP-1 is the silver bullet. I want to go on it. When they find out that it's an injectable, Mrs. Smith then goes from 70% likelihood to 24% likelihood. And we know that, insulinization in people with type 2 diabetes takes about 7 years, right? I'm a person with juvenile diabetes. Doing a weekly, daily, monthly injection, right? It's not the most fun thing in the world. And then when the folks find out that it's not fully approved in all instances by the FDA, the likelihood that somebody wants it drops down to under 20%. Then, as Byron was saying, once they find out that they're likely to regain the weight once they stop taking the therapy, drops down to 9%. So there's a really strong opportunity to create a strong engagement pathway, reach out to those members and educate them on what it actually means to be on a GLP-1, right? And get credit as the health plan to say, you know what, Mrs. Smith, here are the alternatives for you. If you want to go on a GLP-1, great. But let's make sure that you know what you need to be successful. And then make sure that you have the lifestyle therapy programs so that when Mrs. Smith wants to start that journey, she knows what she needs to achieve and those options are available to her. And then when somebody is ready to move to that next step, maybe start on a frontline defense or go right to a GLP-1, how do you ensure that that lifestyle program is connected to a clinical program, right? Doesn't have to be the same provider. And then that can easily be prescribed. But I think what the industry is starting to miss is, unfortunately, they're just looking at obesity as the condition, right? And they're forgetting that Mrs. Smith may also have hypertension. She may also have type 2 diabetes. She may be struggling with mental health issues that contributed to her weight gain in the first place, right? So if we just focus on the clinical therapies for obesity and miss all those other chronic conditions where you're connecting the pieces, you're really siloing care even more just by introducing this new therapy. So what success require? Next slide, Taylor. First is, as we talked about, how do you take those lifestyle variables and transform them into the clinical event codes so that you can create the proper clinical workflows and be transparent to the member about what they need to do. Second is, how do you connect all of those data points so that if they're in Weight Watchers, and even Weight Watchers and Sequence are not fully combined right now, that the clinical program knows what that person is doing in the lifestyle program, and maybe even be able to share that back with the individual's PCP. then rather than have the point solutions define what the clinical workflow and the success criteria is to the health plan, make sure that there's flexibility for your clinical teams and your CMO to define what it is that should be done, right? Is it that Mrs. Smith needs to be in Weight Watchers for 2 months? Is it that she needs to be in it for a month? Is it that Mr. Smith needs to read 5 articles and watch 2 videos? Or do you want all of that just to be focused on, did they do enough lifestyle intervention to lose some weight up front, right? And make sure that there's a comprehensive set of solutions so that you're not setting a one-size-fits-all example, and that you're really treating the individual as an individual needs to be treated to get to success. And then finally, set those clear expectations, right? By defining that clinical protocol for the individual, being transparent about what they need to achieve, the person's going to be okay that you said you have to do this, this, and this to get to your GLP-1, as long as they know what the success criteria is, and as long as they know why some of those collars are in place, because GLP-1s aren't for everybody, right? And you have to overcome what the influencers are looking for.
No, Ed, it's a really important point about this notion that GLP-1s aren't for everybody. We're having too many folks be convinced that this is the first or the best option for them, and it's undeniable for many people. It's a reasonable option, but it's not always the first. It's not the first step. There are other things to do before we get to a point where these are routinely prescribed as the leader. And I actually don't think we'll ever get there. I mean, like I said, lifestyle remains the foundation, and there are things to work up to with it. So it's a unique time, as Mary mentioned at the very beginning. Not only we've seen high cost medicines before, but not at this scale, where half of the general population or more is eligible for a medicine that's really expensive year over year. And it's a challenge for everybody, but there are solutions that work and things that we can do to help guide people to decisions that, with full knowledge, they can come to on their own and feel good about. With that, that concludes the formal part of our presentation, but we'd love to open it up for conversation and questions, either in the chat or otherwise, around reactions, questions, comments about how you're thinking about this in your own plan, or comments about the general landscape. We'd love to take the opportunity to talk through some of those with you based on what we're seeing in the market. And Ed, while we wait for questions, I'd love some of your comments on, we've talked to a lot of folks about the operational challenges here, and a little bit more about how technology makes this different than other step therapies that we've seen in the past, and the traditional approach to step therapy and prior auth.
Yeah, as we talked about, traditionally step therapy is very much patient clinician driven. You go in every 3 months, right? You're going to intensify that individual, as you know, right, from your practice. And here, and I think increasingly we're likely to see a combination of non-traditional and traditional care settings kind of come together. And technology is able to transform those data sets to triage the individual through that workflow. And it's yet introducing another data variable to what has been a pretty complicated interoperability roadmap. But I do think that there are solutions out there to be able to transform that data and power those clinical workflows, right? So certainly, we have been doing that for years. It's how we bill through claims, by transforming those variables. But what's also important is that, unlike step therapy in traditional settings where it's just a pharmaceutical intensification, for success here and for success in emerging chronic condition management variable programs, it's really about ensuring that non-traditional stuff is combined with traditional stuff, so that you're supporting that person holistically and looking at those non-traditional variables to continue to move them forward.
Well, in terms of the other question about being able and willing to offer these medicines. If there are comments on, who in the group is thinking about, yes, we're going to prescribe GLP-1s, or we've made a blanket recommendation, no, we're not going to be prescribing them, or it's more complex, somewhere in the middle, I'd welcome you to put that in the chat, and we can talk a little bit more about some of those aspects of things. I think the other question for this group, in terms of the technology piece, are there other questions about how technology can enable these step therapy pathways, or whether or not, is this a problem you're seeing on your side as well, in addition to the folks we've already talked to?
Hey, Byron and Ed, this is Katie. One of the questions that I've heard just speaking with clients about this is, we talk about the data exchange, but can you maybe go, this is probably more of a question for you, go into that a little bit, can we make it as easy as just telling that pharmacy team or that prior authorization team, yes, no, this person has met that criteria? Or is there going to be more analysis that needs to be done on the pharmacy team side?
No, certainly, as the health plan sets whatever the care protocol is, we can create just a list of all those users with their member IDs or whatever identifying criteria, and be able to send that directly to the pharmacy adjudication team. So we can pretty seamlessly and easily integrate into whatever the workflow is, and
Great.
provide all the supporting information that's necessary to get into the systems.
And Ed, could you talk about some of those data variables in particular? You mentioned a few in passing, but could you elaborate on some of those?
Yeah, so time in the lifestyle program, number of articles read, videos watched, group interactions, health coach interactions or health coach minutes, and then percent of weight lost, right? Those are the big 4 or 5. There's certainly more, but those probably cover 85% of the data that would be needed to confirm that somebody has done something to be able to intensify their treatment.
And give that visibility into what has an individual actually done in the program, in terms of objectively collected data elements, without having to do an extensive chart review or pick up the phone and call somebody, but automate those kinds of workflows.
That's right.
It's I think for anyone who's ever had to do manual chart review, that's a welcome, which I do every day on my job. When I work clinically, that's a welcome addition to the landscape.
And Byron, I'd say for you, as you're always up on the latest literature and kind of looking at the studies, as you look at kind of the emerging lexicon around GLP-1s, what are you seeing as some of the suggested best practices around introducing step therapy or incorporating other, whether it be mental health or condition management solutions to ensure that you're holistically treating that patient?
Well, I think that this is a time where a new pressure is forcing us to rethink our model. And on the one hand, we've felt for a long time that obesity, there's always been this sense that obesity is a failure of willpower, and that has been dispelled now for quite a while, that there's much more complexity to that, a combination of environment, individual genetics, mental health. And so it does require a comprehensive approach that manages lifestyle change, again, that foundational change, with pharmacotherapy, and even at the very pointy end, bariatric surgery has been an option for quite a while. But I think what we're seeing is that there's a return to some of these earlier approaches that say, let's make sure that we're really wrapping the most support around the individual, because this is a very individualized decision. Just because someone carries extra weight doesn't mean they're unhappy or needing a medicine immediately. Actually, if you look at the older anti-obesity medicines, a relatively small portion of the population who's eligible are on those medicines. And I think part of that is we haven't thought as much about pharmacotherapy as we are now. But now that we are confronted with a new drug, but that's very cost ineffective, we're returning to some of those prior approaches and thinking about recognizing this as a big problem. How can we layer on even more support than saying, hey, let's do a lifestyle change program. Let's do a lifestyle change program and think about your mental health and think about your food environment and think about your musculoskeletal care. Are you have a nagging knee injury that's keeping you from getting the physical activity you want? And really breaking down those barriers one by one so that we can optimize someone's health. And then, and only then, once those pieces are in place, decide if a medicine is even the right choice, irrespective of coverage. Is it still the right choice for somebody conceptually? And then, we get to the pointy end where the rubber hits the road is how to pay for these. But I think it's actually really great to see the conversation move back towards wrapping a lot of support around overweight and obesity, around cardiometabolic disease, because these are neglected. They're super prevalent. They lead to a lot of morbidity and mortality, form of heart disease, strokes, kidney failure, the like.
Yeah.
And we can do something about them. And we're just discovering that we can do a lot more than we thought we could before.
Yeah, it's great from a clinical perspective that this is really pushing us forward on how we think about the patient, and would love to know from the folks in the audience, right? As you think about challenges with GLP-1s today, are you thinking about introducing those step therapy approaches, or is it really cost and prior auth that you're most concerned about? And certainly, we always want to hear your feedback and be able to follow up on what it is that we're thinking about. I mean, I'm sure you can hear Byron and I are both very passionate about the subject. So would love to share more and follow up with any of you.
And it looks like, Ed, our poll is live. So
yes.
It says I'm not allowed to vote as a panelist, which I feel a little slighted by, but I'll let it go. But curious if folks can take a minute. We're just asking, which of the following is your most pressing priority for managing your GLP-1 challenges? So is it the prior auth workflow, making that more efficient? Education on what being on a GLP-1 really means? Introduction of step therapy in the path to pharmacotherapy? And then longitudinal coordination of care for members who are struggling with obesity. I mean, all of these are, really high level issues. It's hard to pick one, but if you have some insights into that, we'd love to hear them, and that'll be reflected in the poll when we take a break.
And we will, with that, thank you all for attending, and we'll send out a transcript and the recording of this to everybody who is here. And we look forward to speaking to you at other Blue Venture events and other webinars that we're hosting.
Thank you again to everybody. Reach out anytime. We really appreciate everything. Take care.